What's going on, y'all? What's up? Let's do some Uworld. Share my screen. All right. Hopefully, you guys can see the screen here. So, we got a question here about post-herpetic neuralgia. So, let's see. Patient had self-limited rash in the trunk and now has continued burning pain and hyperesthesia in the area of the rash, suggesting post-herpetic neuralgia, which you treat with gabapentin. Acute zoster is due to reactivation of the varicose zoster virus. As the viral replication diminishes, the skin lesions resolve and the pain typically fades. However, persistent pain for more than 4 months indicates post-herpetic neuralgia. So that's what this guy has. Approximately 5% of patients show low incidence with shingles. The risk is greatest in those with advanced age, severe initial pain, or severe rash. Okay. Post-herpetic neuralgia often improves over time. Resolution may take years, and the severity of pain usually warrants pharmacologic treatment with anticonvulsants like gabapentin, pregabalin, and tricyclic antidepressants. I would start with gabapentin. I don't like the side effects of TCAs. Too much anticholinergic toxicity. Topical capsaicin, that sounds pretty cool. Spicy, lidocaine. Okay. I'm not going to do opioids for post-herpetic neuralgia. That would have to be really severe. Okay. Let's continue. So what do we have here? 9-year-old boy brought to the office by his parents for a well child visit. Okay, pretty general. Examination. Okay, which of the following is recommended regarding exercise? Okay. The father is a certified personal trainer, has created a detailed strength training plan for the child. However, the mother is concerned about safety due to the child's age. The plan includes direct supervisions, which is good. This guy's really young. As well as individualized exercises with light free weights, okay, and weight machines using low resistance every other day. Okay, that's good. Child is eager to begin strength training. He's performing well in the 5th grade and participates in soccer and lacrosse. Very active child. The child has no chronic medical conditions. Good. BMI is above the 85th percentile, so he's pretty big. Okay, sexual maturity rating is Tanner stage 1. Examination is otherwise unremarkable, which the following is recommended. Honestly, I think once you hit the age of 8, if I remember correctly, it's okay to do strength training as long as it's under direct supervision and you're not like overdoing the weights. Proceed with strength training as planned. In fact, that is the right answer. It says, let's see, regular physical activity associated with decreased risk of chronic adult onset disease, such as cardiovascular disease, diabetes, as well as improvements in blood pressure, cholesterol, emotional well-being, and cognitive performance. Children should engage in more than 1 hour of daily moderate to vigorous physical activity, which typically consists of aerobic exercise such as hiking, running, jumping, or swimming. Strength training is a complementary exercise that uses free weights and weight machines as resistance to increase a patient's ability to exert force. Benefits include increased muscle strength, joint stability, endurance, and coordination. In addition, adolescents can increase muscle mass and athletic performance. So yeah, so child readiness, typically age at least 8. Okay. Supervision, as I was saying. Proper technique. This overweight, otherwise healthy boy shows interest in strengthening has shown cognitive maturity. Okay. The first strength was A. The first strength training until adolescence due to cognitive immaturity. We really don't have. I'll grab some gum real quick. Alrighty. Alright, guys. Fantastic. Let's continue. 74-year-old man comes to the office for a scheduled follow-up after hospitalization for a myocardial infarction. Okay. About a month ago, patient has now new cardiac symptoms, has no new cardiac symptoms, and has adhered to his outpatient medication regimen. Following most appropriate pharmacotherapy. Okay. I just don't feel like my old self. Patient's usual routine has been disrupted since he was discharged. He is not meeting with friends. Okay, so has not been able to read the newspaper all the way through. He naps on his couch during the day and wakes up earlier than he wants to in the morning. Patient's medical history includes diet control, diabetes, hypertension, obesity. Medication include aspirin, metoprolol, atorvastatin, lisinopril, nitroglycerin. Low mood. Slowed, subdued. We need to treat the depression, man. This guy's having a hard time dealing with post-MI issues. Desipramine, I think that's a TCA. I'm not going to do that. I don't like TCAs. Mirtazapine, well, I mean, we could consider it. Phenelzine, MAO. We're not going to go for MAO immediately. That's a good option, honestly. SRI, I don't see why not. Trazodone, why? He's having trouble sleeping a little bit. I'm not going to go for that. Venlafaxine, SNRI, why? So we have citalopram. I don't think you can use citalopram in post-MI patients, so absolutely not. Why would we start with an atypical antidepressant? Let's start him on a regular SRI sertraline. Yeah. This patient exhibits symptoms of major depressive disorder, which includes low mood, anhedonia, impaired concentration, so siege caps, right? Sleep disturbance and psychomotor retardation. Major depressive disorder may occur in up to 1/5 of patients who have a recent myocardial infarction. It may affect adherence to post-MI medical treatments and can increase the risk of cardiac mortality. Treatment options include psychotherapy and antidepressant medication. Combination therapy is likely to be more effective and is therefore recommended. SRIs are used as first-line treatments after an acute MI because they are generally well-tolerated and compared. Sertraline is preferred because it carries a very low risk of adverse dressing drive, especially with cardiac medications. I guess that's a good point to keep in mind. Sertraline is good for post-MI depression. Citalopram, absolutely not, because of this QT prolongation. We will not do that. So we mentioned that. We remember that. TCAs, why would we do that? TCAs also have an effect on the heart. Mirtazapine. Sedation and weight gain. Yeah, good point. MAOs, nah. Tachycardia. Increased blood pressure. Good point. Great. All right, let's move on. Now we have a 56-year-old man, progressive urinary frequency, urgency, hesitancy. Frequency, urgency, hesitancy. Which of the following most likely cause? I mean, BPH maybe? Let's see. A patient also reports new onset low back pain. Interesting. Perineal pain during ejaculation. Maybe a prostatitis. He has had no dysuria, no good. Smoked a pack of cigarettes daily for 30 years. I don't like this particularly. Signs are fine. No suprapubic or costovertebral angle tenderness. Good. Examination of the external. Okay. Rectal examination was increased anal sphincter tone. And a smooth, slightly enlarged prostate. There you go. Many leukocytes. So the UA. No blood. PSA is normal. Great. I mean, this guy has prostatitis. In the epididymis, we would have seen like a mass on physical exam of the testicle. Hyperplasia of prostatic stroma. I don't think this is pure BPH. I mean, it says slightly enlarged. Maybe let's keep it. Malignancy, no. His PSA is no. Non-infectious chronic prostate inflammation. Resistant? How do we know it's resistant? Urothelial neoplasm. Nah. This is prostatitis, bro. Yeah. All right. Chronic prostatitis, chronic pelvic pain syndrome. So two names, chronic prostatitis, chronic pelvic pain syndrome. Typically defined as chronic pelvic pain for more than 3 months without an identifiable cause, can present as voiding difficulties, irritative voiding symptoms, pain with ejaculation, or blood in the semen. Patients are generally afebrile, have little or no prostate tenderness with a normal UA and negative urine culture results. Prostate-specific antigen levels are often normal. There is usually no history of urinary tract infection. Chronic prostatitis or chronic pelvic pain syndrome can be categorized as exclusion. Antibiotics are often helpful in symptom relief. Other interventions include tamsulosin and finasteride. All right. Great. Scrotal pain. We didn't have that. Great. All right, let's continue. We have a 38-year-old woman, Rabida 2, para 1, 28 weeks gestation. So She's in the third trimester, comes to the office for a routine prenatal visit. What are we asking here? Which of the following is the best next step? All right, let's see. The patient has no abdominal pain, vaginal, good. Okay, she reports no active fetal movement. Okay, reports active fetal movement, that's good. The patient has been on antiretroviral therapy since beginning. Been on HIV 3 years ago, and her last viral load was undetectable, good. Negative syphilis, negative hep C. Blood pressure is good, good. Non-tender fundal height 28 corresponds, great. Fetal heart tones are 140. The rest of the examination is normal. Okay, hemoglobin is 10, so she's anemic for sure. Delusional anemia can happen in pregnancy. Who knows if that this is what's going on here? Platelets seem check. Platelets are low. Well, actually, they're within range, and the leukocytes are slightly low. I mean, she does have HIV, so I'm not really surprised. Now, alk-Phos is normal, according to this, in the third trimester, but I don't like these liver studies. Something's happening. Ultrasound on the right upper quadrant shows no stones or dilation of the common bowel, so it's not a biliary issue. I mean, what are we going to do with these elevated LFTs in the third trimester with anemia and some leukopenia? Anti-nuclear antibody? Like, are we concerned about lupus in this case? Nope. Delivery? I mean, she's stable. Why would we do that? Serioloplasmin? Yeah, well, not really. A viral hepatitis? She's negative for hep C and syphilis. What about hep B? Yeah, I don't know. I mean, it's a tough question. Tough question. She doesn't have like a viral prodrome right now. Could this be something like preeclampsia? I just don't like those liver studies. Why would we go straight into that? Let's do the viral hepatitis. Yeah, there you go. So let's see. Viral hepatitis should be considered in pregnant patients with a hepatocellular pattern of liver injury, even in those with negative screening tests as initial prenatal visits. So we're just concerned that she might have that because it's just dangerous for the baby. The differential for abnormal liver enzymes in pregnant patients is broad and includes diseases specific to pregnancy and those that affect the general population. This patient has a hepatocellular pattern of liver injury, elevated transaminases with a normal alk-Phos. So it's from the liver. That's why it's called hepatocellular. In association with the normal vital signs and otherwise normal lab values, this presentation is most concerning for viral hepatitis, likely hep C, even if her prenatal visit showed a negative hep C test. Viral hepatitis should remain on the differential for any patient with hepatocellular liver injury, even in those with negative screening tests at their initial prenatal visit, because the disease can be contracted at any time. And antibody testing may not detect those with very recent exposure. Patients with a history of other bloodborne or sexually transmitted disease may be an elevated risk. Most patients are asymptomatic. Although acute disease can cause pain in the right upper quadrant, nausea and jaundice, acute hepatitis often causes markedly elevated aminotransferases. However, most patients develop chronic hep C in the following weeks to months and have less significant aminotransferase elevations. How do we... honestly, I make a card out of this just because, like, I guess it wasn't evident immediately. Okay, come on. Why is it being so slow? Okay, let's add it into a card here. Wonderful. All right, let's keep going, lads. All right, we have a 45-year-old woman brought to the ED by ambulance after a neighbor found her in an obtunded state. I don't like that. An empty bottle of medication. Which is the following most appropriate next step? All right, the patient had a tonic-clonic seizure, so seizure, not good. Just to use that as a sign of what the hell was the intoxication. Depression and pain. So she may be a painkiller, an SRI, an antidepressant. Okay. So she clearly is febrile, hypotensive, tachycardic. Patient reports to painful stimuli. Good. Pupils are not really sure about this number. Normal. Warm, flushed, anticholinergic. The lungs are cleared, auscultation. The abdomen is soft, non-tender bowel sounds are decreased, anticholinergic. Warm, flushed, anticholinergic, no anxiety. Duration of 130. That is prolonged QRS, increased from a month ago. So something's going on with anticholinergic. I am thinking a TCA overdose here, and I don't like it because it's hypotensive, cause seizures, cause warm flushing, cause decreased bowel sounds, cause prolongation of the QRS. So how do we treat it? So this is TCA overdose. No, this is gonna worsen it. That's the one. Maxol, leave it out. Naloxone, this is non-opioid. She's breathing. Sodium bicarb. Is it sodium? Actually, I think it's sodium. Yeah, it's sodium. Yeah, for TCA overdose. Not bad. What's calcium gluconate for? Cardioprotective. There you go. So it blocks the cardiac fast sodium channels and decreases myocardial conduction velocity, leading to QRS prolongation with risk of VTAC. Bolus. I wonder why though. Sodium bicarb helps in TCA overdose. Let's ask chat. How does sodium bicarbonate help in TCA overdose? Chat always has the answer. In TCA overdose, the most life-threatening toxicity arises from the blockade of cardiac sodium channels, leading to a widening of the QRS complex and a risk of serious arrhythmias. We know that. Sodium bicarb therapy addresses this in two primary ways. Alkalinization. So what does that mean? Raising the extracellular pH causes TCAs to become more ionized, which reduces their ability to penetrate cell membranes and block sodium channels. Oh, interesting. Oh, interesting. So basically prevents the intracellular incorporation of the drug, so the TCA can no longer prolong the QRS and prevents that stuff from happening. Great. All right, what do we have here? 23-year-old woman. She pulls up to the office for trouble with her bowel movements. Despite experiencing an urgency to use the bathroom, the patient frequently strains. Whitish appearing anal discharge. Okay, I don't like that. Itchiness, no pain, fever, good. Patient reports several new male. Okay. She's febrile. Mucopurulent anal discharge without perianal abnormality. Perianal abnormalities. I mean, so she has this mucopurulent white anal discharge. Sexually active woman with several new male sexual partners. I'm thinking anal intercourse. Now we have some sort of STI, Crohn's disease. It's not on my differential. This is, sure, this will be more chronic. E. coli, not really. Giardiasis, nope. This does sound like gonorrhea. I'll go with it. Also known as gonococcal proctitis. It's transmitted through receptive anal intercourse, direct spread from the vagina. From the vagina, I'm messing around. Mucopurulent anal discharge, occasional rectal bleeding. So this patient with new sexual partners has developed tenesmus, straining with minimal stool production, and mucopurulent rectal discharge, a presentation concerning for gonococcal proctitis, unprotected sexual intercourse, tenesmus, mucopurulent anal discharge. Honestly, I don't really know what the word tenesmus means. Let's look that up. Describe the sensation of needing to defecate urgently and frequently, despite having little or stool to pass. Okay. Rectal fullness, bleeding, rectal pain, constipation can also occur. Confirm with NAT testing for the rectal swab. When co-infected with chlamydia, they should be treated with dual antibiotic therapy, so ceftriaxone, doxy to cover both pathogens. Great. Wonderful. Let's keep going. We have a 74-year-old woman brought to the office by her daughter due to behavioral changes. Okay, so old woman, behavioral changes. Which of the following is the most appropriate next step? Over the past month, the patient has become more withdrawn. She no longer watches her favorite television shows and seems less interested in her family. Daughter has noticed increasing forgetfulness. Past 3 years, but assumed it comes with aging. Over the past year, the patient has stopped doing her daily crossword, difficulty remembering to eat and clean herself, and has occasionally failed to recognize her grandchildren. The MOCA is low, so we're talking about dementia, but why? Serum TSH and vitamin totals are normal, so we got rid of organic causes, ruled them out. She's probably depressed. How long has this been? Over the past month, so more than 2 weeks. Okay. Let's treat it. We need to have a low threshold for treating depression in the elderly. Initiate amantadine? No. That's for Parkinson's. Initiate fluoxetine? Sure. Rivastigmine? It's allegedly for the mouth. Oh no, this is for Parkinson's as well. I don't want to do that. Let's treat it. What? Wow. You got me there. I thought it was depression, but I guess it's not enough symptoms. That's what they're going to say. Yeah. God damn it. Wait. So over the past month, she had all these symptoms, but she's noticed increased forgetfulness over the past 3 years. Man, although the etiology of Alzheimer's disease is not well understood, histopathologic examination of the brain tissue in affected patients indicates a selective loss of cholinergic neurons. First-line treatment for cognitive symptoms of Alzheimer's disease is a cholinesterase inhibitor, which may improve quality of life and cognitive function. Although drugs in this class have not been shown to alter the disease course in any type of dementia, so it just slows it down. Donepezil, galantamine, and rivastigmine are effective in patients with mild to moderate AD. Let's make this into a card. So we just need to think about the timeline with these questions. Think a little harder about the timeline. I can't just settle for that. Let's keep going. Happens. 24-year-old woman comes to office with a 4-week history of joint pain. Could be a lot of things. So the following most likely diagnosis. She has moderate achy pain and swelling in multiple MCP joints. So we're talking about these right here. MCPs. With lesser pain in the wrists, knees, and elbows. Okay. Fevers at the onset of her pain, but has been afebrile. Ibuprofen has helped, so NSAIDs help a little bit. Okay, no redness, warmth, or swelling any joint. Yeah, I mean, I think this is just a transient synovitis. I mean, this woman probably she has children, two young children, and they probably get ring viruses home. Sometimes when you get viral illnesses, you get these transient arthralgias, transient synovitises throughout different joints. So I'm going to go with viral arthritis in this case. And that is, in fact, the case here with the young kids and everything. Symmetric polyarticular arthritis with a brief cell-limited course. In light of her exposure to young children, this is likely a viral arthritis due to parvo B19. Viral arthritis is often associated with joint swelling and tenderness, but objective findings may be subtle or absent. Whereas children with parvo typically present with the characteristic slapped cheek rash, erythema infectiosum. The arthritis with parvovirus B19 may resemble early rheumatoid arthritis or SLE and may be associated with a weakly positive rheumatoid factor antinuclear. Okay. So the thing here is that it's a symmetric polyarticular arthritis that's self-limited with a person with children. Yeah. Yeah, you can get a pure red cell aplasia as a crisis in people with underlying hematologic disease. Going. 17-year-old girl pulls up to the clinic with 3 days of burning sensation while urinating. Today she noticed spotting on the toilet after voiding. Patient sexually active with 3 male partners and did not use condoms. Regular monthly menses and received outpatient treatment for PID last year. Okay. Patient recently completed a course of antibiotics for group-based strep pharyngitis. Okay. Nitrites, glucosinolates, and blood. Like pathogen. I mean, she's got blood. She has a UTI. Why would she have staph? Candida, no. Chlamydia, absolutely not. Pseudomonas, no. Trichomonas, I think it's E. coli because of the nitrites. Pretty diagnostic of E. coli. Dysuria and abnormal urinalysis are consistent with a urinary tract infection. A UTI is typically acquired when enteric bacteria, most commonly E. coli, are introduced to the vaginal introitus and ascend the urethra to the bladder. Women are at increased risk for UTI due to a shorter urethra and a smaller distance between the anus and the urinary meatus. Recent sexual activity is a common predisposing factor because bacteria can enter the introitus during intercourse. Symptoms of UTI commonly include dysuria, urgency, frequency, suprapubic pain. Hematuria can also occur. Pyuria with leukocytes, nitrite specific or gram-negative treatment. Yeah, there you go. Wonderful. We got it. Let's keep going. Now we have a 7-year-old boy. Pulls up with his father due to nighttime bedwetting. Which of the following is the greatest risk factor for this patient's nighttime bedwetting? Patient was daytime toilet trained by age 2, but has continued to wet his bed about 3 nights a week, leading to several canceled camping trips. The patient urinates 5 or 6 times during the day and has no urgency or dribbling. He has soft bowel movement every day. His father achieved nighttime dryness at age 9. Okay. It's the family history of bedwetting that is most consistent here. Let's see. Primary nocturnal enuresis is defined as nighttime urinary incontinence in a child age more than 5 who has not achieved a prolonged period of nighttime dryness. A family history of bedwetting is the greatest factor for developing this condition. Okay, let's keep going. 88-year-old woman is evaluated for a progressive decrease in appetite and weight loss over a span of 3 months. She has no nausea, vomiting, abdominal pain, or diarrhea. No nausea, vomiting, abdominal pain, or diarrhea. Echo is significant for a long history of hypertension and slowly declining kidney function. She has edema. So she's anemic. I don't like that. It's a actually I think it's normocytic. Yeah, it's normocytic anemia. Platelets, normal. Let's just check. Normal, bicarb, normal. Blood, urea, nitrogen, I don't like that to be when it's high. Okay, it's chronic kidney disease, so who knows. Calcium. Low. Glucose. She doesn't really have fecal occult blood is negative. No. Pan scan. But we need to look for a secondary cause of hypertension here. Probably renovascular hypertension. That's pretty good. All right, Les, thank you for joining me.